Hello, everyone. Thank you for joining us. I'm Dave Lefkowitz, a neuroradiologist and medical director of MRI for Simon Med Imaging. Before we begin, just a few words about what led to this presentation being prepared in the first place. For the radiologists in the audience, you are all too familiar with the phrase non-specific ischemic changes as it applies to white matter lesions found on conventional sequences. Is it infarct, reactive gliosis, demyelination, or something else? You may have thought, wouldn't it be nice to do better than that? There was a time, with the advent of DTI, that diffusion tensors were hoped could serve that purpose, but it hasn't quite worked out. Now with synthetic MR, and more specifically myelin imaging, we have a new tool in our toolbox. We are now finally on the cusp of doing better than non-specific white matter changes. This should not be surprising. After all, myelin is such a ubiquitous molecule. How it is concentrated in infarct or reactive gliosis should in theory be quite different. This is a short presentation, so it may not be possible to convince everyone in 23 minutes of slides and 4 minutes of 2 case walkthroughs. But the goal is to provide examples of what it looks like, how it works in clinical cases, and how it can be used to enhance reporting. Please be patient through the first few slides, which give some technical background. The myelin and fun begins shortly after the 3-minute mark. This is a clinical talk, but we begin at the beginning. A general overview of synthetic MRI, including post-processing, is described in this paper. This is the pulse sequence diagram and signal intensity equation for each voxel. The terms are mostly familiar, including proton density, TE, TR, and TI. The novelty comes from R1 and R2, relaxivity constants that represent the inverse of T1 and T2. These can be calculated because of the timing structure of the pulse sequence. This provides for the calculation of quantitative relaxivity and proton density maps, from which all other conventionally weighted sequences are then generated. From this, multiple weighted images are calculated, generating contrasts such as T1, T2, proton density, flare, double inversion recovery with CSF and white matter nulling, and phase-sensitive inversion recovery. Although eliminating conventional acquisitions is feasible, that is not the subject of this talk. Rather, it is the calculation of a unique weighting based on myelin concentration. That will be the focus of the cases presented and the approach to image analysis. In addition to conventional weightings in myelin, quantitative maps provide superior segmentation of the brain into gray matter, white matter, and CSF compartments. These are tabulated into a compact table demonstrating white matter, gray matter, CSF, and myelin totals for the entire brain, as well as the percentage of brain and intracranial volume each of these components represents. Some of these metrics are then combined and plotted onto population-based reference curves. Intracranial volume, brain parenchymal volume, CSF volume, brain parenchymal fraction, myelin content, and myelin parenchymal fraction. Before getting to some cases, we begin with the myelin images. The standard display employs a green to yellow scale of myelin concentration, which covers the range of 0 to 40%. This reflects the native concentration of myelin in various brain tissues, which ranges from near 0 in gray matter to roughly 40% in the corpus callosum. Note that the standard display on the left overlays the green-yellow myelin map onto T1 weighted images. This can be turned off, as shown on the right. But the pure myelin images are a bit disconcerting to view, with black replacing gray from the combined T1 plus myelin version. So the cases that follow use the standard output. As we scroll up, note the shades of green-yellow in the Pons. Thalami. And Centrum Semiovale. When we look at white matter lesions on T2 and flare, the question we will be asking in every case is how much myelin is present within each of them. I don't use ROIs for routine purposes, but this gives you a rough idea of what to expect in the Centrum Semiovale. Thalami. And Pons. The most important reference curves are for myelin, represented as an absolute value for the entire brain summed on the left, and as a percentage of brain volume on the right. Critically, two standard deviation ranges are displayed with yellow dots for the current case, and values at the top of each curve. With that, let's look at some cases. We will start with MS, arguably the most obvious use for myelin imaging. This case has lesions in the periventricular, deep, and juxtacortical white matter. On the myelin image, notice how the myelin content tracks quite closely with lesions on flare. There is dark gray showing within all lesions, representing the background T1 weighted image upon which the myelin is overlaid. Notably, there is little or no preservation of myelin in association with each flare lesion. The underlying tissue is essentially devoid of myelin. Same case, a subcortical eufiber lesion is shown on sagittal flare. Double inversion recovery and axial flare. The myelin image reveals an absence of myelin. Since the lesions on myelin images are similar to those on conventional weightings, a real added value of synthetic may be the reference curves, which provide powerful additional metrics of overall brain health. To begin, the brain intracranial volume is normal, but the absolute brain volume is low. Further, the brain parenchymal fraction, its percentage of intracranial volume, is lower still. But that's because the CSF volume is high. So, in short, this is an atrophic brain, not at all uncommon in MS. In addition, the absolute myelin content is low. as is the myelin parenchymal fraction, the percentage of brain volume comprised of myelin. So this is not only an atrophic brain, but one whose myelin content is pathologically reduced. Again, this is not at all surprising in MS, but these are quantitative and clinically relevant metrics of brain health. Next up is chronic white matter infarct. The central cystic encephalomalacia, of course, has no myelin. But what about the surrounding flare hyperintense rim? Well, no myelin there either. But this is not always the case. Here we have a variety of irregular ischemic changes. Note this lesion's appearance on flare and DIR. And now on myelin, where the center has no myelin, but the periphery has some. Flare and DIR show multiple lesions, but the myelin content is variable. Flare and DIR show a larger deep parietal lesion. The center has no myelin. The periphery has moderate myelin loss. Flare, DIR, and myelin. The right periatrial lesion has almost no myelin. The left periatrial lesion has mixed myelin. This pattern repeats itself for severe white matter disease. When you are reading a case in clinical practice, the images won't come with arrows, at least not in 2021. In this series of slides, decide what you think of the lesions on the T2 flare and DIR, and then see how they compare on the myelin image. T2, flare, and DIR, myelin. 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 Now, it's fair to ask, how am I going to report this? Well, as with MS, there are too many lesions to describe. What is more clinically useful is global disease burden. Again, the reference curves serve this purpose. This brain's volume and parenchymal fraction are normal, so it's not atrophic. But total myelin content and myelin parenchymal fraction are 3.2 and 2.8 standard deviations below the mean, respectively. So the global white matter ischemic burden is substantial. Here are 3 similar lesions on the same slice. But the myelin loss is mild, moderate, and severe. If a lesion is subtle on flare and DIR, does that mean it will likely have largely preserved myelin? No. Here is a pontine lacune. One of the shortcomings of synthetic is increased noise, especially in the pons and medulla. But the multiple weightings help. There is no myelin, so it's an infarct. So, to summarize myelin images in white matter ischemia, familiar lesions on T2 and flare only partially correlate with myelin loss. Myelin images provide added value by accurate characterization of myelin loss. Reference curves provide global measures of disease burden. The next clinical setting is traumatic brain injury. Just two examples will suffice to illustrate focal and global changes. Here is an example of post-traumatic temporal lobe focal atrophy on flare and DIR. But what about the T2 flare hyperintense rim? In this instance, the rim has no myelin. One slice higher, the myelin loss is also matching the encephalomalacia on flare and DIR posteriorly. But anteriorly, flare and DIR look normal, while there is additional myelin loss that would otherwise be undetected. Global effects of TBI are illustrated in this 46-year-old. Visually, there is just too much green on the myelin images. Not so obvious to visual inspection is the increased generalized atrophy for age, but the ventricles and sulci do look a bit prominent. The reference curves for brain parenchymal fraction and myelin content parenchymal fraction confirm these visual observations with global metrics of 2.4 and 4.1 standard deviations below the mean, respectively. Another familiar appearance is periventricular capping, most commonly adjacent to the frontal horns. This was described decades ago and termed Ependymitis Granularis. Even though it is considered to be a normal variant, the underlying tissue is noted to have patchy ependymal defects, astrocytic gliosis, and increased water content. Notably, myelin content was described as low. In this case, and others I have seen like it, myelin content appears completely absent. A first cousin of this is the periventricular halo. Notice the complete halo of DIR hyperintensity, as well as the small, deep white matter ischemic focus. Here is the myelin image, where the halo is shown to have no myelin. And the ischemic focus is also shown to be devoid of myelin and is therefore an infarct. Here is a halo with no myelin. But outside the halo, there is a lumpy pattern of periventricular ischemic changes. And these exhibit variable myelin. Here are small frontal caps with no myelin. There are large right and smaller left ischemic changes in the deep parietal white matter, with decidedly variable myelin. Same case, a periventricular halo and ischemic changes on the right, ischemic changes on the left. Myelin is absent in the halo and highly variable in the ischemic changes. Same case, lots of supraventricular deep white matter ischemic changes. Myelin content is highly variable. Lastly, a case of occipital capping or periventricular infarct with no myelin. It's probably apparent by now, but these two possibilities are not currently distinguishable. If the periventricular halo is due to transependymal edema, as with hydrocephalus, then absence of myelin would be expected because of the model used for segmentation. This is beyond the scope of this presentation. However, suffice it to note that myelin fibers infiltrated with edema are not visible. This brings us to a related situation wherein myelin is made invisible, peritumoral edema. This is a mesothelioma metastasis near the start of treatment on flare and post-contrast T1. 12 days later, the extensive surrounding edema continues, which appears to be devoid of myelin. But is it really? 8 months later, the edema has resolved. All that remains is a thin rim of encephalomalacia. Now look at the myelin image. The myelin is back, except for a small defect corresponding to the encephalomalacia. So, was it really gone in the first place? No, it was not, but simply masked by the edema infiltrating myelin layers. Once the edema has resolved, most of the myelin has moved back into the so-called fast relaxation compartment and is again revealed, with only the encephalomalacia exhibiting myelin loss. The final case, before we go to the how-to portion of this presentation, is the appearance of perivascular spaces on myelin images. Obviously, there is no myelin within the perivascular space, but first look at them on T2, flare, and DIR, and then on myelin, where the spaces are more conspicuous and a bit larger. Again, T2, flare, and DIR, and then myelin. T2, flare, and DIR, myelin. These images through the right lentiform nuclei show that one particular large perivascular space has a central black hole and a hyperintense rim on DIR. The myelin image shows that both compartments are devoid of myelin. This is not surprising, given the nature of vessel pulsatility and its potential impact on adjacent tissue integrity. It is enough to make me wonder, though, whether they are simply innocent phenomena. So to summarize, myelin imaging can be used to evaluate the entire brain and focal lesions. Both global reference curves and myelin images provide novel tissue characterization. The clinical settings are nearly universal, but global pathology has been illustrated in these cases for MS, TBI, and ischemic changes. Focal myelin loss has been shown to be severe for MS, highly variable for ischemic changes, severe for periventricular halos, capping, and peritumoral edema. However, with the caveat that tissue edema may mask underlying intact myelin. And for perivascular spaces, where myelin loss may be slightly greater than generally recognized. This concludes part one, and now we move to the case review for part 2 of this presentation.
The first case I would like to walk through is multiple sclerosis in a 31-year-old female. Let me find the relevant images in the series tray. We'll bring down myelin, double inversion recovery, T2, and flare. Scrolling in the periventricular white matter, we can see characteristic white matter lesions on the conventional sequences. The corresponding lesions on myelin show virtually complete absence of myelin within each of them. What about the global effects? The global reference curves show that the brain is essentially normal, although the brain fraction at 1.8 standard deviation below the mean is approaching abnormal. The myelin content is 3 standard deviations below the mean, while the myelin fraction is 2.1 standard deviations below the mean. How does this translate into a report? Here we have my description of the conventional images. Chronic multiple sclerosis disease burden is mild to moderate with characteristic lesions, mainly in the periventricular and deep white matter. The additional sentence characterizing its appearance on myelin states the myelin images demonstrate a complete absence of myelin within all lesions. Here we have the global analysis showing the 6 parameters with values and standard deviations. Notice that these are within fill-in fields to facilitate reporting. These are summarized in a single sentence at the end. These metrics reveal a low but normal brain fraction as a percent of intracranial volume, however low global myelin content and myelin parenchymal fraction.
The next case is chronic white matter ischemia. How can this be quickly analyzed and reported? Let's find the relevant images on the series tray. Here's myelin, T2, flare, and DIR. Starting from the top, we can see substantial ischemic changes and corresponding myelin loss, that's variable. Scrolling down, left lentiform nuclei, and substantial ischemic changes in the Pons with myelin loss. What about the global effects? Here are the reference curves showing that the brain size is normal. The myelin content is 3.3 standard deviations below the mean. The myelin parenchymal fraction is 2.7 standard deviations below the mean. So how is this additional information incorporated into routine reporting? Here we have my description of the ischemic changes in conventional terms without the myelin characterization. This paragraph is the synthetic analysis with myelin content described as being substantially reduced within the above noted ischemic changes, and then another sentence describing the global metrics, including standard deviations. And that's it. We have seen how myelin can be utilized as a marker for tissue integrity underlying flare and T2 hyperintense lesions. Reporting this can be kept simple and limited to a single sentence. Either embed this into the existing description of white matter changes or as part of a separate paragraph which also includes the global analysis. The global reference curves provide a picture of overall brain health. Most important among these are the myelin content and myelin parenchymal fraction metrics. But brain parenchymal volume and parenchymal fraction are also valuable. Using fill-in fields facilitates reporting. I recommend adding a single sentence following the tabulated metrics to highlight the key observations. The last thing referring clinicians want is a sea of numbers they have to slog through. Always try to make it easier for them. With that, the formal presentation is concluded.